morning, everyone. We'll begin in a few moments. Good morning, everyone. We're going to begin in just a few moments. Go ahead and let us know where you're from in the chat. Let us know what country and organization you're joining us from. My name is Susan Melnick, and I'm the Communications Specialist here at ASAP, Accelerating Support to Advanced Local Partners. And I'm really happy to have you all here today. We have quite a number of people registered for this webinar. I think we hit over 800. So really looking forward to see how many can join us for the live webinar. And don't forget that we'll have the recording available for you to share with colleagues or to rewatch tomorrow morning. We'll make sure that's online. So we'll just wait another moment. Good morning to those just joining us. Go ahead and put your name and organization and country in the chat so we can see where you're joining us from. We're just going to wait a few more moments and then we'll begin. Just a quick note about today's webinar. We're going to have a number of polls that are going to pop up on your screen throughout the webinar. So feel free to fill those out. We'll give you about a minute per poll. They're short so that you can answer them. And then we'll continue on with the webinar. Due to the fact that we have a lot of information to cover today, we may not be able to get to everybody's question. So I'm going to go ahead and share a frequently asked question document from our last webinar on the same subject in the chat. And feel free to look through that and see if your questions are already answered. All right, I think we'll wait just one more moment. While we're waiting to begin, I'm going to go ahead and add that frequently asked question link to the chat. Again, we may not be able to get to everyone's questions today, so please feel free to download this file and take a look through and see if your questions are already answered in the document. And I'll share it again in the chat in a few moments. Excellent. Okay, well, I think we're good. We'll go ahead and get started. My name is Susan Melnick, and I'm the Communications Specialist here with ASAP, which stands for Accelerating Support to Advanced Local Partners. We are very proud to be a USAID and PEPFAR program. And I'd love to introduce Carolina Mejia, who is our Director of Measurement and Learning here at ASAP. Go ahead, Carolina.
Good morning, everyone. Good afternoon. Glad to see that so many of you have joined. We have a very exciting presentation, very practical, very insightful. So we want to get started as soon as possible. So can I ask for the next slide? All right, so here, just to get us started, Susan has already mentioned about your introduction in the chat. Tell us where you're from, and you're aware of the Q&A box for any type of questions that you may have that may not have been answered in the frequently answered questions that Susan circulated. As she mentioned also, we're going to have some polls that we would like for you to answer. They're going to be quick because we have a lot of questions, so you'll probably get a minute to answer them. They're quick quick questions, and then to make sure that you're understanding the material being presented. And then we'll also let you know that today's presentation is also going to be emailed, as Susan mentioned. Next slide, please. ASAP has a lot of content on demand. So we have webinars that are on our website. There's currently about 65 webinars that we have produced. And so we would like for you to feel free to go back to those and take advantage, because there's really good information that you can benefit from. Next slide, please. We also have material that's available in 3 languages, in English, of course, French, and Portuguese. And here you have a search option where you can choose the language, or if you're looking for a specific topic, you can also do that. And so it makes it easier to find what you're looking for if there's something specific. Next slide, please. And we also have the capability of being able to download those PDF presentations as well as the recordings, so that you can have them on your computer. So feel free to go to our website for IntraHealth, and then under ASAP, you will find all of these materials. Next slide, please. Okay. So here comes the good part. We're going to get started with introductions. I am very pleased to be able to introduce our 2 presenters today. I'm going to start with an introduction for Robert Jose, who is an international development professional with over 20 years of extensive working experience in monitoring, evaluation, management, information systems, and project management, including 12 years specifically in performance management and quality assurance, quality improvement of public health, and HIV programming. Since February 2019, Robert has been working as a program and data quality advisor at the USAID Office of HIV, providing technical leadership in data and program quality assurance and improvement. Prior to this position, he served in roles ranging from program management to M&E in various large international organizations and private foundations, including CARE International, Save the Children, and the USAID mission in Haiti. Weber holds an MBA from the University of Illinois and associate degrees in statistics and 2 bachelor's degrees in engineering and applied economics from the State University of Haiti. Anna Shaw has close to 20 years of global health and development experience, including senior technical and management roles with the USAID government, implementing partner organizations and healthcare providers. Since she joined USAID in 2010, Anna has worked at a number of HIV and Global Health Bureau-wide HIS and M&E projects. She currently serves as the Office of HIV/AIDS Evaluation Branch Chief, where she leads the evaluation and improvement of USAID programs and data quality. Before joining USAID, Anna worked with the VA in Kaiser Permanente on leading data-driven quality projects. Anna has subject expertise in HIV, TB, nutrition, and mental health, and of course, extensive research in M&E in program and data quality and health system strengthening experience. Anna received her undergraduate and graduate degrees from the University of Belgrade and the University of California at Berkeley. So it is my honor to introduce to you our 2 presenters. Over to you, Robert and Anna.
Thank you. Good morning, good afternoon, everyone. Depending on where you are. As you can see, this webinar this morning, the focus will be on the USAID PEPFAR program in data quality assurance and improvement. Our focus will be much more on tools and processes. why we are thinking about this focus on program and data quality assurance and improvement. We think that it's very important for you to understand some critical and very important concept, the concept related to quality assurance and improvement. We think that it's very important for you as well to understand when USAID staff travel to your site to visit your activity, to conduct either program quality activity or data quality activity, you understand exactly what tools they are using, what the process is, so that you can feel confident about what's going on. And on your side as well, you can understand what action need to be taken to make sure that you are reporting high quality data or you are ensuring quality of the services being provided in the site where you are implementing activities. Next slide, please. Let's start by a few very important concepts. When we are talking about quality assurance or quality improvement, even continuous quality improvement, what does that mean? First, quality assurance, this used to be defined as an activity to measure performance against standard at specific point of time. In short, when we are talking about quality assurance, we are talking about how to identify issues or gaps. This is what we are, in short, this is what we can say about quality assurance. When we are talking about quality improvement, if I have to consider literally what used to be written about it, quality improvement can be defined as an evidence-based activity to continually improve performance, test changes in services, measure the effect of these changes, and use data to improve clinical performance and health outcomes for clients. In short, policy improvement refers directly to action taken to address issues or gaps identified. And when we consider the overall concept, what we call continuous quality improvement, this is an ongoing process to engage implementing teams in identifying barriers and facilitators of improving quality services and empowering them to take actions. That means when we are talking about continuous quality improvement, it's like the overall, we consider the overall framework, taking we identify issues or gaps and then taking actions to improve them. It's like a continuous process. Next slide, please. As we said when we just started, this webinar will focus on data and program quality assurance and improvement. Let's start by data quality. What does that mean, data quality assessment? When we are talking about data quality assessment, what does that mean? I'm sure that a lot of you are familiar with data quality assessment. Just it's kind of a reminder for most of you. When we are talking about a data quality assessment, this is a quality assurance activity assessing one or more indicators and one or more dimensions of data quality. That's when the focus can be on one indicator, that can be on more than one, and also that can be on one dimension of data quality, that can be on various. And as you can see in the brackets, the various dimensions of data quality, validity, accuracy, and other ones as mentioned on the screen. What used to be the purpose of a data quality assessment? The purpose of data quality assessment is much more to ensure that high quality data are being reported. Even we highlight some key stakeholders to which we will have to report, as you as the implementers will have to report to the Ministry of Health, to USAID, to PEPFAR, but you will have also to report you may have to report to men, but you can be a sub partner and reporting to the prime. That means any data being reported, there's a need to ensure that they are high quality. And this is the purpose of a data quality assessment. How data quality assessment used to be conducted. Data quality assessment used to be conducted by identifying system issues that can affect the quality of the data. Data in conducting data quality assessment, it's expected as well to validate site level data aggregation and reporting process, to identifying and take action to rectify discrepancy between number reported and number recounted, and also identify how we can strengthen staff capacity in data management and reporting. And like last but not least, we will have also, by conducting data quality assessment, we will be able to identify issues related to program quality and identify action to be taken to address them. Next, please. What could be the focus of a data quality assessment? Just share with you a few examples so that you can understand. Data quality assessment can occur at any level where indicators are measured. Any level, whenever data used to be collected, indicators are used to be measured. That's when you report on these indicators. The data quality assessment can be conducted at those levels. As example, you can see on the screen, data quality assessment can focus. It can be focused at system level. That means you can focus on indicators related to supply chain, to lab, to information system. You can focus as well on the cascade overall. Like we can focus on prevention, indicator related to prevention, testing, treatment, viral load. Similar, you can decide that your DQA can focus on specific population, key population, orphan and vulnerable children, or AGYW. That means data quality assessment can focus on any indicators at any level. Next, please. What are some key challenges that can affect data quality? Why I'm trying to put this focus on all this concept is just to make sure that you understand why we conducted, what does that mean, data quality assessment, why we are conducting data quality assessment, at what level data quality assessment can be conducted, and also what can be some challenges that can affect data quality assessment, the quality of the data, so that action can be taken at those levels. First category of challenges is system-related issues. There might not be enough, or there can be lack of adequate resources for data collection and analysis. There can be some issue related to the fact that data flow don't follow patient flow through a cascade of services. It can be because patient monitoring and reporting systems are not well designed and managed to accurately generate a reportable result. It can be because in the organization or in the site, roles and responsibilities are not very well defined. We don't know who is in charge of data entry, who is in charge of aggregation, who is in charge of validation, and who is in charge of reporting. In some instances as well, there can be some issues due to the fact that you are not collecting data directly. You depend, or when I'm saying you, your organization or your as an organization, you depend on other entity that can be a public site, to share with you data related to the activities, and you don't have full control on completeness of this data, and also there might be some delays in getting this data on time. That's mean this type of dependency can generate some data. There can be some challenge with this type of reporting or this type of reliance that could affect the quality of the data. There are some other factors. I won't talk too much about them, but you can read directly from the slide. There can be some factors like misunderstanding of the indicator definition. Someone who doesn't understand exactly what does that mean, what the indicator mean, how to compile the data, how to tally the data and report. If you don't understand properly how to do it, there can be some mistake. If you don't have appropriate training, when you are entering data, you don't understand that this is as important as analyzing the job that other staff are doing by writing the report. If you don't pay attention, if you are not motivated enough when you are entering data, when you are validating the data, there can be as well some issues with the quality of the data being reported. Next slide, please. Why for us at USAID OHA, or when we are referring to the USAID PEPFAR, USAID PEPFAR, why we have this specific emphasis on data quality assurance and improvement? First, as you know, the HIV program, HIV programs are result-oriented, and all decisions are based on data and evidence. And we, in the program, we know we know that high quality data are essential, not only for monitoring and evaluation of progress towards the 95 target. We need also a high quality data to ensure accurate assessment of the performance of our partner. We need as well high quality data for accountability and good governance, as well as for planning and decision making. And we need data is used generally to assess compliance between service quality of the services being provided, and as well with standard and technical guidelines. Next, please. On the previous slide, if you can go back a little bit very quickly. Okay, you can see at the bottom there is a visual. In this visual, one of our focus in the PEPFAR, USAID PEPFAR program, we focus on the fact that you can see on this visual, we have a program data quality on the left side and and program quality on the right side, and in the middle, they meet somewhere together. Is that we are trying to illustrate how you can, by conducting, how you can hit two birds with one stone. By doing one activity, you can get both of them, data and program quality, where they meet together. We can see some example next page so that you can understand better my reference to this slide. In this slide, I try to point out for you how data quality can affect program quality and performance. I put two main examples, and I will explain why, how with this example, data quality can affect program quality as well as performance. First example, site inaccurately reported a high number of HTS posts. The number of patients are tested positive, the number reported, the site reported accurately higher number than what exactly they have been doing. Based on this number reported, which is higher, we expect, or it's expected, that there will be an increased number of patients enrolled and maintained on ARC, because they report that they identify a lot of patients HCS positive. If there are a lot of patients HCS positive, there should be more patients enrolled and maintained on treatment. We expect as well there will be more drugs for this patient. Given that they reported inaccurately, that means they will receive more drugs than what is needed for the site. And in addition to that, given that they reported that they have more patient HCS positive than what they have effectively, there might be, we may think, that they need more staff than what is needed to support this, the site. Based on this number reported inaccurately, a lot of decisions will be taken, and they will be bad decisions. They will get more drugs than what they need. They will get more stuff than what they need, and you can see resources will be wasted because of this bad reporting. Similarly, if a site underreported the number of patients, USAID can decide, or can decide to put the partner on performance improvement plan, thinking that they are not doing well, but it's because they don't report accurately data related to what they have been doing. Similarly, they will receive less commodities when we compare to what is effectively needed, because they reported less, they will receive less, but they need more. Similarly, they may have less staff than what is needed. Next slide, please. This is a poll. Just would like to make sure that you get the point on what we have been talking about very quickly. Please, first poll. First one, true or false. ZQA can be conducted only on the care and treatment indicators. Only one choice. Thank you. As you can see on the screen, 94% say false. Good response. We have seen in one of our slides that ZQA can focus on any indicators. Second question, true or false, ZQA issues can affect quality of the services being provided? True. We have seen two examples on how quality of the data can affect the quality of the services being provided. That's good, wonderful. The third one, main factors that can affect data quality. Yeah, very good. 79% say all of the above. Yes, all of the above. Not only each specific one will affect, but the best option we can select here, that will be all of them, because all of them affect quality, can affect quality, data quality. Thank you everyone for your participation, and I can say that you understand properly what's going on so far. Next, please. Next slide, please. Now let's focus on USAID OHA data quality assurance and improvement approach. Why we would like to focus on USAID OHA data quality and improvement approach? First, we would like to make sure that you understand that all of us, we have our own, or like we are responsible. We are part of a action that can be taken. We have our own role and responsibility in data quality assurance and improvement. This is the first one. The second one, I would like to make sure that all of us, when all of you participate, you understand that the what USAID staff used to do or envision to do when they are talking about conducting a data quality assessment, how information related to data quality assessment can be analyzed and action that can be taken. Next slide, please. First of all, data quality assurance and improvement, this is as I mentioned from the previous slide, this is a shared responsibility where everyone is involved. On this visual, you can see there are 5 levels or 5 layers. The first one, we are talking about USG data quality assessment. This used to be a data quality assessment mandated by SGAC. SGAC generally in various OUs requested to conduct data quality assessment, which used to be comprehensive data quality assessment with involvement of all the USG agencies, including as well other stakeholders like the Ministry of Health and UNAIDS, WHO, even Global Fund. All stakeholders involved in HIV-related activities in a country, they used to be part of this type of a SGAC mandated data quality assessment, which used to focus generally on treatment indicators. Same USAID in country, they may decide that there's a need for them to conduct a data quality assessment. This is what we consider as the second layer in this visual. And USAID staff may decide to conduct a data quality assessment, focus on any indicator that they think is important for them to focus this data quality assessment. And in addition to that, USAID staff will have to conduct what we call routine data quality monitoring. This specific activity we envision that the USAID staff, as well as third-party contractor, will have during monitoring visit, during SIMS assessment. We'll talk a little bit about SIMS as we are moving forward. They can also decide at any time to conduct what we call routine data quality assessment. That will be data quality assessment using similar tool than what can be used for ESGA, for USG GQA mandated by ESGA, by OGAC, or data quality assessment specific for USAID. They will use exactly the same tool, but they will consider only a sample. Based on the sample of a patient record, based on a sample of site, they will be able to take decision on how to address any data or program quality issues that can be identified. We will talk a little bit more about the tools as we will be moving forward. But in addition to that, what is very important for you guys participating to this in this training as implementing organization, there is a need. It's expected that all implementing organization, they conduct routinely data quality assessment. This is the fourth component, the fourth layer in this visual, routine data quality assessment that need to be conducted by implementing partner. Because you, as we mentioned from the very beginning, any data being reported need to be you need to ensure that these data are high quality. But the fifth layer, this is where we highlight or we outline better how this is a joint responsibility where everyone need to be involved. Any data quality or program quality issues during any of this exercise related to 1, 2, 3, or 4, there's a need to take action to address all any issue identified. This is what we call joint quality improvement. For joint quality improvement, will be addressing any data and program quality issues identified, and everyone will get their involvement in taking this action. Not only USG, you as IP, and also staff working in the site or Ministry of Health. Everyone will be involved. Next, please. Let's talk in more, we provide more information about the PEPFAR comprehensive data quality assessment. What is the process? What are the main steps? Main step will be, as we mentioned initially in one of our previous slides, data quality assessment will focus on assessing the system. The one step will be to assess the system in order to identify data management and reporting issues, and also figure out the pathway to address these issues. Second step in the data quality when conducting a comprehensive data quality assessment is to focus on patient and data flow mapping. You need to understand the patient flow and also identify any potential bottlenecks on how data patients are moving across the service delivery process. And third step is the data verification. For the data verification, we have to identify if there is issues with data quality and how serious is the problem. And we need to assess validity and consistency of the result reported, and also perform cross validation between the primary data source and alternative data source. And at the end, to make sure that your issues will be addressed, you need to develop an action plan where you highlight how issues identified will be addressed, and based on the findings from system assessment and also from data verification. Next step, please. Next slide, sorry. We mentioned the step, how the data quality assessment will be conducted. Now, the information, how we will be analyzing the data. To analyze the data, we put emphasis on two main components. We put emphasis on the verification factor, which measures the percentage of reported data that could be verified by manual creation of the indicators numbers. The verification factor is like a measure on what percentage or how the number recounted and the number reported are matched. We do a kind of you can see the formula on the screen. We say verification factor is the number recounted over the number reported by 100, so that you can see at what percentage we are accurate, or we are close to what how to say that. We are trying to figure out at what level there's exact match between what is reported and what has been recounted. There's an example just below. As an example, if we have 80 people reported for TX care, like currently on treatment, and from the DQA, we were able to find that only 78 should have been reported for this indicator TX care. That means we will have a verification factor, as you can see the formula, recounted over reported. Recounted, we have only 78, reported 80. That means 78 over 80 by 100, that, which is equal 97.5%. What we observe, we can observe that this number is lower than 100. When it's lower than 100, we talk about over-reporting. That means what has been reported is greater than what has been what we were able to recount. But if the verification factor was greater than 100%, we would talk about under-reporting. Under-reporting, that means what has been recounted is greater than what has been reported. I hope you get it. And in addition to the verification factor, we consider as well as the second measure for in our analysis, the concordance, which is the alignment between the selected data element in the primary data source and the secondary data source, where we have concordance equals number of files matching over the number of files reviewed by 100%. Next slide, please. We have been talking about the verification factor, and the verification factor, as we mentioned, is a number recounted over number reported by 100%. But this verification factor, there are some decisions that can be taken depending on the level of this verification factor. If we have a verification factor greater than plus or minus 10% points, 10%, that's lead us to think about serious data quality issue. That means whenever you have a verification factor of 110% or 90%, greater than 110% or greater or lower than 90%, there are serious data quality issues. And because of that, there are decision rules that are defined where we can where specific action need to be taken to address the issues identified. Action that can be taken are routine data quality assessment that need to be conducted 1 quarter after the DQA where the issues are being identified. As we mentioned, routine data quality assessment is need to be conducted by you guys, IP. USAID or third party may lead comprehensive files audit, and data quality monitoring by USAID or third party will follow approximately 1 quarter after this DQA or the LDQA where issues have been identified. And capacity building for IP staff or staff working in the site need to be conducted. That's mean whenever you have verification factor greater than 110%, or verification factor lower than 90%, these actions are expected to be taken because there are serious data quality issues. Next, please. If we have verification factor between plus or minus 5% and plus or minus 10%, we talk about moderate data quality issues. When we are talking about plus or minus 5%, between plus or minus 5% and plus or minus 10%, we are talking about verification factor between 95% and 100, or between 90 and 95%. When we have this level, this verification factor, the action that need to be taken to address these moderate data quality issues are the following below. IP will need to conduct comprehensive patient file audit, and a quarter later, the quarter after the patient file audit, USAID will conduct data quality monitoring in 10% of the site, and also routine data quality assessment, including 25% of the site where issues have been identified must be conducted. Routine data quality assessment, as we mentioned, will need to be conducted by you guys, IP, but you have to include 25% of the site where issues have been identified. And then once more, capacity building for staff working in the site where data issues have been identified must be conducted. Next slide, please. What need to be, after conducting a data quality assessment, we have seen the process, we have seen how we analyze the data, and what need to be follow-up action. And next, please. For follow-up action, after conducting a data quality assessment, these follow-up action below can be taken. Quality improvement action plan need to be developed to address the system, data, or program quality issues, and the findings from the data quality assessment need to be compared with, there need to be cost analysis between the findings from the data quality assessment and performance data that used to be reported. And there's a need to update the number of reports already reported to make sure that we take into consideration the findings from the data quality assessment. If there are any discrepancy, you need to report the data that have been validated, the number validated. There's a need to update the number already reported. And then DQA report must be shared with all the relevant stakeholders. As we mentioned already, capacity building or technical assistance need to be provided. And supervision combined with routine data quality monitoring may need to be increased. And also there need to be some follow-up DQA to make sure that the proper action are taken to address any issues previously identified. Over, please. Next, please. Another poll, more question, but I think you will, just to make sure that you get all the topic we've been talking about so far, most of you are familiar with. Poll number 2.
We hope everyone can see the poll. I know there were messages that people could not see them, but I hope that's taken care of. If not, please let us know. Thank you. I agree, Anna. I will allow a little more time for this set of questions.
Well, Bear, let me know when you'd like me to turn the poll off. We're at
Yes, please. Yes, no, that would be good. I think that everyone has been able to vote also now. Very easy question. I think you can display. Thank you. First question, who is responsible to ensure data quality? 4%, 1% mentioned USAID staff, no one mentioned MOH staff. 89% mentioned all the above. Yeah, that's the appropriate response. All the above, as we have seen in the shared responsibility, in the slide on shared responsibility multi-layered approach, you can see that there are various levels of data quality, various layers when data quality assessment can be conducted, as mandated, or USG data quality assessment, USAID specific, and our ZQA as well by IB. And as we mentioned as well, when we talk on the first slide about data quality assessment, what does that mean? Everyone reporting data on any indicator, there's a need to ensure that these indicators or the data reported are high quality. So data quality, ensuring data quality is the responsibility of everyone. All the above is the appropriate response. Second one, true or false. GQA can be conducted only by USAID staff. 90% false, that's perfect. As we have seen in the shared responsibility, and as mentioned for the previous one, everyone can conduct a data quality assessment, not only USAID staff. Third one, facility reported 130 patients newly enrolled on ALC. During ZQA, 150 patients were confirmed. That's mean recounted was 150. Oh no, I lost it. Okay, thank you. And then the answer need to be 115. This is the right, you are almost close, but 115 is the right response. As we mentioned, verification factor is number recounted, the number confirmed, 150, over the number reported, 130. 150 is greater than 130. That's when you will have a number greater than 100, 115. This is exactly the right answer. Wonderful. Fourth one, facility reported 120 patients. This is what has been reported, 120 are being current on treatment. And during GQA, only 110 were confirmed. That's when the number recounted is 110. We are wondering, can we talk about over-reporting or under-reporting? What you can observe that 100 were confirmed, were recounted, but they reported 120. They reported more than what we were able to validate. That means there was over-reporting. 70% they provide the appropriate response. They reported over than what need to be. Over-reporting is the right response. 5, from comparing the numbers recounted with the number reported for TX score, we found a verification factor of 112. That's mean a discrepancy of 12%. This percentage of discrepancy can be considered as acceptable. 81% false. Yes, you are correct. That's perfect. This is what we've been saying. Whenever we have greater than 110%, this is not acceptable. There are very important issues that need to be addressed. Thank you, everyone. I can see that most of you get properly what has been said so far. The other ones, just read once more the slide after the training and you will get it better. Thank you. Next slide, please. Now let's talk about the USAID treatment data quality tools. Why we think there's a need to put some emphasis on these tools is much more. When USAID staff are conducting, or even interagency staff are conducting a data quality assessment, we would like you to understand what tool they are using, just for transparency. You understand exactly what they are looking for, how they will be managing the process, and then you won't be surprised about what they are doing. It's not we are trying to catch you that you are not doing well. No, just would like to make sure that you understand the process, what we are doing, and also that will help you as well figure out how to improve your your data management system, or to identify how you can use similar tools if needed. Next, please. First of all, we would like to bring to your attention, and we would like to put some emphasis on this on that. USAID doesn't prescribe which tool our treatment partners should use when they conduct their data quality check or routine data quality assessment. We don't prescribe, USAID doesn't prescribe any tool. The tool that we'll be presenting today is a USAID tool that was based and aligned with our PEPFAR CDC DQA tool used for interagency data quality assessment. All the USG data quality assessment we've been talking about, this is exactly similar tool that they have been using, and this is this tool that we'll be presenting today so that you can understand what the process used to be. With this tool, we extend beyond just assessing and validating our treatment number to support program, and also we extend beyond assessing and validating the numbers. We also support program quality improvement more directly by using this tool. And a very important caveat we would like to bring to your attention as well: when anyone is using this tool, we would like anyone using this tool to pay specific attention to protection of personally identified information to ensure confidentiality. No names, no address, no phone number should be recorded. And in all the file should be password protected. It's very important, it's critical, and we would like to bring that to your attention. Next slide, please. PEPFAR treatment DQA. First, why we focus on treatment? We focus on treatment DQA because the treatment, when we are validating or conduct a data quality assessment on the treatment indicators, we can get a better picture of the overall performance of the program, given that the TX score as an indicator provide a broader view of the program. This is one key component. The second one aspect why there was this focus on treatment is the fact that when you are assessing the clinical cascade, the treatment TX score as an example, you will see when we go over the tool that we have information related to HIV diagnosis. You can have information, you can validate numbers related to testing, number of tests performed, or HIV, number of HTS pose. You can also, you are able to validate TX new, you are able to validate TX cure. You are able also to validate a number, or to check any issues with viral load. You are able also to validate any issue with MMD. This is why we focus a lot on treatment, and you will see as we will be moving to the tool, as you will see. In terms of overall context, when we the PEPFAR treatment DQA focus on full recount, and this full recount used to be required by OGAC. With any OGAC mandated DQA, they request full recount of the number that has been reported for a specific quarter. We also streamline the DQA process to inform program quality, as we have seen in one previous slide, where we have the two circles at the bottom, where we try to combine or to ensure that program quality and data quality can meet in the middle. And also, with this treatment DQA, we are able to address all the challenges related to interaction and treatment definition. In some countries, we know there are two definitions ongoing, 28 days and 90 days. With the tool that we will be talking about, it will be possible to address very quickly challenges related to these two definitions without any confusion. And with this treatment DQA as well, you will be able to assess and address system-related issues, as we have been talking about. There can be some system issues that can affect quality of the data being reported. How is the tally sheet? I put focus first on the tally sheet. In the tally sheet, this is an Excel format. That means everyone with a computer with Excel can access this, can use this tool. And we have about 19 data points or variables, depending on where you are. And some of them, the first one can be filled out before traveling to the site. And the other ones need to be 15, need to be filled out on site. And at the end of the GQA, you will have information about discrepancies between number reported and number validated that will be automatically generated in the tally sheet. And also you will be able to see if there's any issues in terms of compliance with standard of guidelines for quality of services. Next, please. In terms of tools, if you remember well, when we have been talking about the step or the process, we have system assessment, we have patient and data flow mapping. This is the tool that need to be used for patient and data flow. For patient and data flow, you have to, like using this tool, there's no need to ask the question one after the other one. It's like trying to get a better, like an overall understanding of the patient and data flow in the site where you will be conducting a data quality assessment. Next, please. This is a Word document. The second tool, data quality system assessment, as we have been saying, the process, data flow mapping, system assessment. The system assessment, Word document as well, a list of questions that can be asked to understand the system, the data management and reporting system, to figure out if there's any issues directly linked to the system that can lead to any kind of data quality issues. Next, please. The next tool is the tally sheet. We have data flow, system, tally sheet. For the tally sheet, as we mentioned, this is an Excel file, and we have some data points. The first 4 can be filled out before traveling to the site. At the top, you can see the quarter being reviewed. And then on the site, you have to fill out 1 row for each patient information, or the information in each of this column. This is what the data entry screen. Next, please. At the end of the data entry, there's this you have this tab automatically generated with a DQA summary where you have current on ART. If in a country we have the guidance of 90 days, you have active defaulter and total current on ART for 90 days, male, female, and overall. You have the new on ART, male, female, and overall, and where these are related by month. And in the tally sheet and also in the guidance with the tally sheet, it's possible you can change the quarter to have, instead of January, February, March, you can have other months. It's possible to tailor the tally sheet to your specific context, to what you need to do to make sure that you can have new on ART disaggregated according to the month that you are reviewing. And then you have also current on ART using the PEPFAR guidance for 28 days. We can have 90 days or 28 days without any risk of confusion between the two definitions. All this used to be generated automatically by the tally sheet after data entry in the previous screen. Next, please. And at the end, overall, you have this tab fill out, the column highlighted in orange. You will have to enter the number reported, the number you entered in that same. For TX cure male, for each age group, you enter the number that you have been reporting, the number you have been reporting, but this column recounted will be filled out automatically based on what has been entered in the first tab data entry. No action will need to be taken on your side on this number. You have only to enter data in the column highlighted in orange. And automatically you have the verification factor that is calculated. And as we mentioned, as we have been talking about in the previous slide, depending on if verification factor is lower than greater than 100% or lower than 100%, you can figure out if there is any a serious problem to be addressed or not. On the other side, we have also, as we mentioned, information about MMZ, information about viral load. If you have number reported, you can compare. Comparison will be done automatically. These are the number recounted or recreated. And if you have number reported, you enter them, and automatically there will be a verification factor or concordance between number reported and number that has been recounted based on what you have been entered. Next, please. This is an example of how data quality and program quality are directly related. When we enter data in this tally sheet, you will be able to figure out, as an example, let me see, you can see some cells highlighted in yellow. If you consider the second one, This patient started on treatment, got diagnosed for HIV on April 24th, 2015, but this patient initiated on ART on October 6, 2019. Wow. Why there is this big discrepancy between HIV diagnosis and ART initiation? Because we are talking about test and start. Why they don't start on time? There's a problem we need to understand. That means there can be some data quality, some program quality issues. All these cells highlighted in yellow put out some potential program quality or service quality issues. As an example, this patient should have been should have got a viral test. There's no information about viral test. Why? That means this is something that we need to understand. That means when you are entering data in the tally sheet, you will be able not only to generate all the information that you have seen on the previous slide, where you can compare number reported and number that has been recounted, but you can see also some program quality issues related to compliance with standard or technical guidelines from PEPFAR or WHO. Next, please. A third poll to make sure that you get, I think that you get it well, but let's have another poll to make sure that you get all what has been discussed. Miss May. You will have only 1 minute. It's quite quick. I think it should be okay. Thank you. Thank you. Yes, very quickly, the first question, the USAID PEPFAR DQA process focused only on company discrepancy between results reported and data validated. 72%, yes, you have the right response. We have seen in the illustrative responses and also from the tools being used. You have seen also from the previous slide, fill out with data that we can see not only discrepancy, but also other issues related to program quality or compliance with standard. False is the good response. The second one, the USAID PEPFAR can help identify both data and program quality issues. 92%, you are correct. That's fine. We have seen that in the previous slide with data. Third one, the USAID PEPFAR treatment DQA process implied the use of the following tools. We use the tally sheet, yes, 1%, 2%, and yes, 74%. You are perfect. We must use all the three tools, A, B, and C. That's perfect. Thank you very much. Before moving with the next slide, just would like to bring to everyone's attention. In the previous slide, we have been talking about, I think it was the first slide under this category where we've been talking about making sure that no PII, personally identified information, is collected given that in the tally sheet we have a date of birth in the tally sheet. What we have been doing in the version that will be available on the website, on our ASAP website, you will, and we provide appropriate guidance as well on how, after entering data in the first tab, that will be data entry 1, all this data will be automatically transferred to a new tab called Data Entry 2. And we provide guidance on how you can remove or delete the content of this Data Entry 1 tab. That means you will not have any more all the date of birth. You will have only age, and you won't have any more any patient ID. That means it won't be possible for anyone to identify which patient have been entered in the tally sheet. That means we in the version that we shared with the ASAP team that will be on the website, you will be able to on their website, and we provide appropriate guidance as well. You will be able to see how to move from the data entry 1, where we have date of birth and patient ID, to data entry 2, where you have only age, no patient ID, no date of birth, no issues with PII. We make sure that there won't be any issue. I hope that can help. Next slide, please. Data quality assessment. When we conduct a data quality assessment, it's not being conducted just to conduct a data quality assessment, but for accountability, to make sure that money being used, we can provide evidence on how money has been used, and also to make sure that ESGAC understand why there can be some update in numbers previously reported. ESGAC requests that data result from data quality assessment can be reported and submitted. Generally, it's expected that to be submitted sometimes in November. It won't be submitted by IP. We are not talking about specific data quality assessment or ZQA conducted by IP. We are talking about ESGAC mandated ZQA or USAID ZQA. Just would like you to understand that ZQA is not conducted to be conducted. They are conducting, and also we have to report. Expect that there can be report. And the report, there need to be this is the content of the report, but it should be, and also what can be reported, any data quality assessment, any data quality improvement, or any other kind of a patient data improvement that has been conducted. All this need to be conducted. Need to be considered. There's a need to report on any of any of them, data quality assessment, data quality improvement, or any other patient data improvement. And the submission can be a narrative component as well as an Excel file. On the right side, provide some specific information on what should be the content of the narrative. Next slide, please. Overall, even you won't have to submit as the IP implementing organization or local partner, you won't have to submit a report to ESGAC, but you will have to conduct a data quality assessment. What need to be the content? What can be considered as an outline of a summary of a ZQA summary report? There's a need to mention the number of sites where the ZQA has been conducted, the number and list of sites where discrepancy between number reported and result reported is greater than 10%, number of beneficiary records that have been reviewed, and any program and data quality issue identified or addressed directly on site or on site, and also any health system issues identified and also specifically addressed on site while you have been conducting the data quality assessment. And in this summary report, there need to be as well action plan to address issues identified, including timeline, staff, and entity responsible. Next slide, please. Some resources. Next, please. Next. Once more, would like to make sure that you get it. I don't want to leave without making sure that you get it. There are various other tools that can be used to conduct a data quality assessment. Using this OHA treatment tally sheet that we have been talking about is not mandatory. It's up to you. As we have been talking about, personally identified information, patient address, phone numbers, names should never be collected during the data quality assessment. If you are using this tally sheet, you have to make sure that the identity of this patient won't be, identity of any patient won't be given. Next, please. Next slide, please. In this slide, just provide to you, this is like a training that has been using this the same tally sheet that I've been talking about, like what I'm saying, the same tally sheet, but with the some specific guidance on how to move from the data entry one with date of birth and patient ID, move from this tab to the patient and data entry two with one age without patient ID and date of birth. In this training that has been conducted by the USAID partner, I put a link. There's a link in this slide where you can access this training and you can see, you can follow the process step by step on how this can be done. I think this resource can be very helpful for you. Next, please. Next slide. Oh, too quick. There was the previous one. In the previous one, I provided also some other some other resources, tools for measure evaluation, and also WHO some tools. Just click on the link and you can access to them on the web. Next, please. Next, please. Next slide. Yes. Now we will be moving to, we've been talking a lot about the data quality. Let's move about and talk about program quality. We'll focus much more on some key tools being used for program quality. Just would like to make sure that you understand what at USAID, what we can request from you, and what also what to expect when they are talking about any of these, using any of these tools, just to make sure that you are not afraid when anyone is talking about SIMS or ESD or any RPGSA, you understand what is it and why it's being conducted. Next, please. We understand that in this context of COVID-19, some activities can be done in person, but there are some challenges with SIMS in various countries because of the COVID restriction. But we'd like you to understand when we are talking about SIMS, so what is it? SIMS is, as you can see directly from the screen, SIMS is a quality assurance method used to increase impact of the PEPFAR program on the HIV epidemic to standardize monitoring of quality of the services. SIMS is a quality assurance method used to monitor quality of services at site or above site level. This is a kind of a survey-based standard. There is a lot of questions, and they will be assessing the question. And based on the question, there will be a score: red, yellow, or green. Red, there's a big problem. Yellow, problem. There are problems that need to be addressed. Green, everything is fine. Next, please. For 2022, just would like to make sure that you understand, even what it's not, you won't be impacted too much, but you need to understand. In FY22 and moving forward to COP22 as well, there will be a big emphasis on SIMS. There are some key priorities. SIMS, currently, we have version 4.1 and we are moving to 4.2. And SGAC is putting a lot of emphasis on ensuring alignment of SIMS with the PEPFAR minimum program requirements. And there are some specific areas like pediatric DTG, like infection control, where there was a lack of a standard in the SIMS tool concerning them, to make sure that we can assess them. SIMS is being reviewed to make sure that we can also assess this standard in the SIMS, in the new version of the SIMS tool. And also, given the context of COVID-19, SIMS is being adapted to make sure that the tool can be used remotely or in a or can be tailored to be used even if there are restrictions for in-person activities. The new version of SIMS will be launched in October 2022. But I would like to highlight for you, this is why I would like to talk about SIMS during this training session. SGAC is like encouraging people or anyone, Ministry of Health, IP, anyone to use the tool The tool can be used by anyone to conduct self-assessment. There won't be any need for you to expectations from IP or from Ministry of Health to report on SIMS, but we at SGAC encourage if we want to use the tool for self-assessment, you can use it to assess quality of the services being provided. That will be helpful for you. Next, please. I will go a little bit quick. Our SIMS Site Improvement Monitoring System. This is a PEPFAR quality assurance method being used by all the PEPFAR agencies, USAID, CDC, ELSA, Peace Corps, all the PEPFAR agencies. They are using it to assess quality of the services being provided. The structure of the tools, we have what they call set. Set is like a group of questions or standard. And we have what we call CAE, core essential element. If you hear someone talking about CAE, they are talking about core essential elements, which are specific questions or standard based on WHO or USAID guidelines or PEPFAR guidelines. And also within each CAE, we have a list of assessment questions. As you can see on the right side, this is the structure of the tool. We have standard where they explain what standard we are assessing, instruction how you will be assessing the standard, and the questions. And depending on the response to each question, you have a score, green, yellow, or red. And they provide a way of explanation about what does that mean, each of the color of the score. Next, please. The SIMS process, just very quickly to make sure that you understand what is it. The SIMS process, we started, there's a need to start by having a prioritization of a site or able site where the assessment will be conducted with appropriate justification. Just for you, if your site, if one of your site is selected, you must know that there was the prioritization. It's not because they would like to, I don't know, to catch you or to do anything about you. It's much more, there was a prioritization and your site has been selected. And then SIMS assessment can be conducted either at site or at able site. Site is where activities are being implemented. Able site is like a supporting. If, as an example, we are talking about a project related to HMIS, Health Information System, they are at able site. Or governance, you are providing support directly to the Ministry of Health, you are at able site. And after conducting a SIMS assessment, there's a need for correction action plan. And the data can be analyzed to make sure that you can improve performance and quality. Next, please. When we are talking about SIMS, there are two types of assessment. There is what we call comprehensive assessment, which used to be the first one. And comprehensive assessment can be conducted only by USG staff or any third-party contractor that USAID can hire. But there's also follow-up assessment. Follow-up assessment need to be conducted within 6 months after a comprehensive assessment. It's much more to rescore any CAE that was red or yellow, and also to track any improvement. Follow-up assessment can be conducted either by IP or by USG. USG staff in country, USAID, may decide that this follow-up assessment, given that you guys, you have appropriate training, you understand the problem, you can conduct the follow-up assessment. That will be a decision from USAID staff in country. That's mean, in short, comprehensive assessment, only USG, but follow-up assessment can be conducted either by USG or IP. If USG staff decide that IP has appropriate training, they can do it. Next, please. I will go quickly on this one. For remediation strategy, we have been talking about action plan that need to be developed to address issues. How they do it is much more based on the score. You analyze all the score, all the response, and you focus on the question that generate the score and understand what need to be improved and how it need to be improved. This is what need to be what need to be on the focus of your decision to when you are developing your action plan, your remediation strategy. Over. Next, please. Sorry. Once more, the corrective action plan, the content, as we mentioned, you can see some specific question, which see it is called red or yellow, what action need to be taken to remediate. And you have to develop a timeline so that the action can be addressed within 6 months. You must be able in your remediation plan to track progress toward remediation and improvement, and identify if there are any above side of policy barriers that affect site level progress so that action can be taken, and identify as well any support that can be needed. If they are site performing well, they can try to make sure to ensure exchange of best practice between site performing well and site not performing as well as other ones. Next, please. How SIMS data are used? Next, please. For you, SIMS data are not collected to be collected. They are collected to identify performance barriers and also facilitate quality improvement. There's a list of other approach or how SIMS data can be used. They can be used as well to deepen, analyze, and guide management and improvement, to prioritize quality improvement as well as quality improvement of core intervention, and facilitate improvement in the quality of services and technical assistance, and ensure SIMS data can be used as well to ensure delivery of services that meet quality standard and demonstrate accountability, identify and take action to address needs for coaching or or design any specific tools that may or SOP that may be needed, and also help identify best practices that can be shared with underperforming site, as we've been mentioning. Next, please. Just would like to bring that to your attention because it's really important. As we mentioned, SIMS data are not collected to be collected. They are collected to do more analysis. SIMS data used to be analyzed jointly with expenditure data to ensure, to understand how financial resources are spent on what and for whom. SIMS data used to be analyzed jointly with the performance data to figure out how or to determine how quality of services are related to performance. SIMS data used to be analyzed jointly with above site investment to identify policy barriers that can affect site level progress. And SIMS data can be analyzed jointly with IP work plan and also with community-led monitoring to make sure that we can understand the barriers and enablers for patients from the patient perspective. Just some example on how SIMS data can be analyzed jointly with other type of data. Next, please. One poll that could be very short. We don't have too much time. 1 minute. Thank you. The first one, one USAID staff can conduct a SIMS assessment. As we've seen, comprehensive assessment can be conducted either by USAID staff or third party hired accordingly. But we've seen as well that follow-up assessment can be conducted either by USAID or USG, or they can be conducted as well by IP. Follow-up assessment can be conducted by IP if USAID staff in country decide that IP can do it, they have appropriate training. And as we mentioned as well, the SIMS tool can be used for self-assessment. If it's being used by self-assessment, it can be used by anyone, not only USAID staff. 76%, very well, you get it. Second one, SIMS data can be used to identify performance barriers and facilitate quality improvement, identify best practice, identify low performing site for punitive actions. No, we are not trying to there won't be any punitive actions for anyone. With SIMS, we are trying to make sure that everyone, we have proper understanding of the standard and we're applying the standard properly. We are all in it together. The appropriate response is D, A and B, 39% got the right response. SIMS can be used to identify performance barriers and facilitate quality improvement, identify best practice that can be shared with underperforming site. Only A and B. We are not looking for or trying to there won't be any punitive actions based on SIMS. This is not what we are looking for. Third one, SIMS is a standalone data stream. Therefore, related data can't be analyzed jointly for the type of data. 77%, wonderful. The last two slides, I think the last slide, we point out how SIMS data can be analyzed jointly with MER data, or jointly with ER data, jointly with CLM data. They are not a standalone. Thank you. Next slide. Other quality, program quality tools and processes. In addition to SIMS, as we know, there are some challenges to implement SIMS in some contexts, but there are also some other tools that we would like to highlight for you that can be used for program quality. Next, please. Maybe some of you used to hear about what is called PDSA cycle model. PDSA, as the acronym is mentioned at the top, plan, do, study, and act. This is a quality improvement process where you start by an action planning. You have there's a specific issue that need to be addressed. You make some assumptions, some hypotheses on how the issue can be addressed, and you define your process. Who need to be involved in this process? What will need to be done? Where and when? That's in the planning stage, and then you start implementing the actions. What you have your action you define, but in the do, you start implementing the action. And based on implementation, you start reviewing the data based on action implementing. This is the study component where you discuss the data, the findings, you compare with original data, lesson learned, and then based on your review, you will take action. Action will be either you adopt the process that was defined on the component plan on your right. Either you adapt, you make some adaptation, or you adopt it, you accept it how it is, or you drop it, you don't use it. If you decide to not use it, you will start over with planning. You redefine your goal, you redefine your hypothesis, and you redefine your process. And you move once more, implementation, and you review. If after reviewing, you take everything is fine, you adopt. If there's some adaptation, you make adaptation. That means this model can be used for any issues, any challenge. You plan, do, study, and act. This is what we call the PDSA, plan, do, study, and act cycle model. Over. Next, please. As you know, SIMS, there are some challenges with SIMS. There are some challenges for in-person activity. In some OUs, USAID staff can't travel to go to site for in-person activity. USAID has been developing a tool called Essential Service Delivery, ESD tool. With the ESD tool, SIMS to be reported to ESGAC, to be reported to USAID HQ. SIMS data used to be collected mainly by USAID staff for comprehensive assessment and for follow-up. As we mentioned, follow-up can be done either by USAID staff or by IP if possible, but we have also developed the ESD, Essential Service Delivery Tool. That is a tool that can be used directly by IP. USAID staff in country may send this tool to you guys as IP, asking you to share information about or to collect information that will be shared with them in the country, and they will share with us as well at HQ, where you can collect data on services or any description of services in your in the site where you are working. That's in the process with a ESD. It's like there might be some service description based maybe to the fact that we have COVID. It can be also because of a political turmoil in a country. It can be because of an earthquake. It can be because of floodings or any issues. There are some services description, and there's a need to inform about the service description. By using the Essential Service Delivery Tool that USAID staff in country will share with IPs, they will fill out respond to all the questions and help us understand why or if there's any service description. And as soon as this is this step here where the tool is shared with mission, and mission share with you guys IP. As soon as you receive this tool, you can upload this tool on any device that you are using, and based on this tool available on your device, you go to the site as needed to collect this data. And as soon as you collect this data, you send them back to the mission in country, and the mission in country send them back to us at HQ, and we can perform any analysis that may be needed, and we can reach out to mission in country may reach out to you to discuss any findings or any issues related to service description. This is just would like to bring to our attention that there might be some need from USAID mission requesting you to use this ESD tool to collect data or to inform about any description of services in the area where you are working. Next, please. Other tool that is used, this is standard, another tool that is being used, but this tool used to focus much more on getting deeper insight into cause of intervention and treatment, and also guide program quality and service delivery improvement. We are talking about what we call the root cause analysis. Based on the root cause analysis is a kind of a process where using findings for the data quality assessment and all the patient on intervention of treatment, or based on the EMR, on your EMR, if there's an electronic medical ecosystem, and also based on the tracing natures, you can figure out how you can track, identify client who miss appointment for over 7 days, how to track them, and how to make sure that how you can understand why they miss the appointment, why they are intervention on treatment. This tool generally is used by USAID mission in country, but in some OUs, I know some IPs has been using this root cause analysis. I think it makes sense for us to share with you this processing tool so that you can have an idea if there are this type of data being collected, why they are collected, and if you are envisioning to understand better why some patients are in interruption of treatment, what can be used in order to assess or to understand the reason or the rationale behind the fact that they are in interruption of treatment. Next, please. Do we have time to have it? I don't know. Very quickly.
No problem.
Thank you. Yep. Thank you. That was very quick. And the first question, what is the main program quality assurance tool used across the PEPFAR program? SIMS. That's wonderful, 71%. That's wonderful. As we have seen in the first slide on SIMS. SIMS is a PEPFAR standard tool being used by all, and as I mentioned as well, being used by all the USG agencies, CDC, USAID, then DOD, HELSA, all the USG agencies. This is the main program quality assurance tool used across the PEPFAR program. That's perfect, wonderful. Second one, the PTSA model can be used only to address issues identified during SIMS visit. False. Wonderful, 78%. That's good. Because as we have seen, the PTSA model planning for any, you make planning for any issues or any challenges identified, and then you figure out action that need to be taken. You review your data, and and also you start by the planning. You do implement, and then you and you take action to make sure that you will adopt or not. That's mean any problem. It's not only SIMS, any problem that can be identified. Yes, false, you're right. That's perfect. Thank you. Third one, what is the main board approaches PEPFAR used in support of continuous quality improvement that was discussed during the session? 75%. That's perfect. All the above. We've been talking about all of them in our session. That's wonderful. Thank you very much. I can see that you get it very well, or most of you get it very well. The other ones, just have a look on the slide deck, and I think you will be able to catch up. Next slide, please. But in addition to all of what we have been saying related to data quality, program quality, data quality improvement, assurance improvement, program quality, assurance quality improvement, we think there's a need for you to understand that it's possible for you as well to assess your own, to perform kind of a auto assessment of your own capacity in terms of strategic information, and as well identify any needs for capacity building. And we share with you, next slide, please. And we would like to bring to our attention this tool that has been, this is a USAID tool that has been adapted jointly with one of the USAID IP, or like the organization funded by USAID. This is what we call the SICA tool. And in this SICA tool, we have, I think, 4 domain: human capacity for strategic information, organizational process for PEPFAR strategic information, technical infrastructure system for PEPFAR strategic information, and PEPFAR data quality use. There are some subdomains based on a list of questions that when you access this tool, you can click on this link and you will access the tool. And based on the response to the list of questions, you can have an idea about your at what level you are, what is your specific capacity in each of these subdomains. If there is any need for capacity building, or any need to improve your organizational structure, appropriate action can be taken. This is a tool that can be used for self-assessment, and this tool can be used as well by any organization that will be providing support to you. That's in USAID for local organization, the sub-partner. I think there is a similar tool, or exactly this tool, need to be used to assess capacity of this organization to make sure that they are ready to properly implement activities. I think that should have been my last slide. Next, please. Yes. Thank you very much. I've been talking a lot, but I think that you may have a lot of questions as well, and available for your question.
Thank you, Will, for a great presentation. And now we'd like to open up the floor for questions.
Carolina, actually, we have a number of questions in the Q&A, and Anna has asked me to go ahead and ask them. So I'm going to go ahead. First one is, can the DQA tools be customized to do DQA for the OVC programs, inclusive of system audits?
Thank you. That's a wonderful question. Yeah, actually, we are working on, I can say there are two things. First one, in the measure evaluation package, DQA tool package, there is one of the tools can be used for any indicator. You can put any indicator there related to OVC or any technical area. But us at the SGAC, at the OHA, the current tool, data quality, the electronic tally sheet, we are working jointly with the OVC team to make sure that we have similar, exactly the same structure, the same approach, the same calculation. We are working on making sure that it can be available, I think, by the end of February, because we envision to conduct a comprehensive data quality assessment in the Dominican Republic. And we think that with using this like a similar tally sheet will be better for us and will be easier to make sure that we won't miss any calculation. Yes, we are working on it, but for measure evaluation, there's already a tool that can be adapted to OVC or any other indicators. I hope I respond to the question.
Excellent, thank you. The next question is, does the follow-up assessment only focus on rescoring the red and yellow sections from the last assessment?
I would say mostly, or the expectation is to reassess only the CEs with score red or yellow. However, country team may decide to check some other CEs if they want. But the overall, the standard guidance is to focus only on red and yellow, the CEs with score red and yellow. I hope you get it.
Wonderful, thank you. We have a couple of questions here on SIMS. Are we sharing the digitized SIMS tools as well?
First, country team can share easily the SIMS tool with the. I have to mention that before working at WAHA, I've been working as well at mission level at the USAID mission. And the process for SIMS, we need, country team need to share the tool with IPs so that they can see the content, they can get ready when the SIMS assessment is being conducted. And also we need, it's one of our main responsibility as USAID staff to make sure that IPs have appropriate training on SIMS, they understand what is SIMS, they understand the content of the tool. But in addition to that, the SIMS tool used to be available on the PEPFAR website and accessible to everyone. This is publicly available. But we can figure out with you guys from ASAP if there's a need, if we can share with you what is available or share a link to the public website so that everyone can download the SIMS tool on the public website.
Certainly, we can add that to the resources for this webinar.
Yes.
Excellent. So another question is, the DQA tools are customized by PR according to the country context, or is it fixed by USAID?
As we mentioned, as USAID OHA, we don't require, or we don't consider as mandatory to use this tally sheet. It's not mandatory. But anyone interested in using this tally sheet can use it. But in terms of tailoring, you can tailor the tally sheet to make sure that your country, because the way it is, you will be able, there's a first tab instruction where you are able to add to change or add the name of your OU, the OU where you are working, put the list of sites where activity will be implemented or where the GQ will be conducted, and also the quarter that will be assessed. It's up to anyone using this tool to tailor the content from the first tab instruction. You can make sure that this tool is for your specific country, will be used in the site where you are implementing activities, and also when the GQ will be conducted, and also the tool is tailored to the quarter you are interested in. I think you may see a version with last quarter of 2019, but it's up to you if you are working on the first quarter of 2022, of FY22, that's in October to December 2021. You can change it directly in the first tab instruction. Similar for ARC regiment, we have a list of ARC regiment. It's up to country when they are using this tool to make sure that all the ARC regiment are exactly the ones being used in their country. If they are the ones, they can add to make sure that the tool fit to the specific needs. I think in terms of tailoring, this is what we expect or what can be done. But as I mentioned initially, there is no expectations for IP or for anyone to use this tool as mandatory. It's like up to anyone using it. But in the guidance that I shared, I think Tally user guide, there's some information on how to tailor the tool. And also in the link to the webinar from the other IP, the other organization that I shared also in one of the slides in resources, you will see the process on how to tailor the Tally sheet as needed if you are using it.
Excellent, thank you. And we have another question here. I'm not 100% sure if I understand this one, so I'm going to go ahead and read it. What was the starting of the quality assurance approach from global to regional and up to national? And what is the future trends of this concept, quality assurance?
Wow. I'm not sure that I can have an accurate response to this question. I can say for me, when I started working in the M&E, there was still a big emphasis on ensuring that you're reporting high quality data. Because for me, and also the way as an M&E specialist or M&E professional, I used to consider reporting high quality data as what we call accountability. You have to be accountable of the money that you got to conduct any activity. And to be accountable, you need to report accurately on how the money has been used. And this is how I consider it. You have money, you do work, and you have to report appropriately about the work being done. And before starting working with USAID, when I was at implementation level, there used to be data quality assessment conducted. I can't remember since when, but there used to be a big focus on data quality assessment from all funding agencies. It's a matter of accountability, making sure that number reported match or are quite accurate, everyone understand properly the definition of the indicators, because any data reported will be used or can be used for decision making. As we have seen is one example in one of our slides, the illustrative example on how data quality can affect program quality or program performance. You were able to see if we don't have high quality data, you will take bad decision, and also you will waste a lot of money. This is how I used to manage or focus on data quality, but in terms of when they start focusing on it, I can't say it some specific date. And what's the future? For me, it will be, this is my own perspective. I don't know, I can't provide a very accurate response, but I can say as well, from my own perspective, there will still be a need to be accountable for any money you get. And also there's a need for you to make sure that any decision you will be taking is based on high quality data, on reliable data. If you are using bad quality data or data which are not good quality, your decision won't be you may be wrong in the decision that you will be taking. This is what I can share. This is my own perspective as well.
Excellent, thank you very much. And we had a question which I think you may have already touched on, but can SIMs be implemented virtually?
Yes. Yeah, no, that's a wonderful question. I've been talking a little bit about it. So far, the process with SIMs for virtual is not fully virtual as we we could think about it as we are now. I'm virtually on my somewhere, and you can see me, and we are together. We're working together. For SIMS so far, since the pandemic, I think March 2020, the planning for SIMS was to make sure that at least one staff can be available on site with appropriate technology, and other ones will be remotely in their office or anywhere else. And the one on site using appropriate technology that can be WhatsApp or Google Meet or any like a video conferencing infrastructure. They can use the video conferencing infrastructure to make sure that the assessment can be done together by one staff on site and other ones remotely. This process apply. This is like the guidance not only for USG staff, but if the assessment is a follow-up assessment being conducted by IP, similarly, there should have been one IP staff on site with appropriate video conferencing technology and other ones remotely to support the SIMS assessment. But now, with SIMS 4.2 that will be launched in October 2022, the process, it will be possible, or we are envisioning, to make sure that the CEs, or like the questions, without any risk of exposing PII, personally identifiable information, all the CEs can be assessed fully remotely without anyone on site. This is what is being envisioned with SIMS 4.2 that will be launched in October 2022. But for the current SIMS, until now, there need to be one staff at least on site with appropriate video conferencing technology. I hope that I respond to the question. Over.
Perfect. Thank you so much. And I think that's it for us today. I'm going to go ahead and share a link to the FAQs that were filled out last webinar. It has a huge number of questions and answers that were answered by the USAID team last time. So I just wanted to again thank everybody for joining us. Go ahead and put myself back on camera. Apologies, I didn't realize I wasn't on there. Thank you all so much for joining us today. I've shared the link that has the resources, several of the resources that were shared today, and we'll go ahead and add the slides and webinar recording tomorrow. Thank you all so much. Thank you to the USAID team and the ASAP team for making this all possible. And we've also shared a link to all the upcoming webinars that we have over the next couple of weeks. So please be sure to sign up for those. And we appreciate you all for joining us today. Any last words from the team?
No, thanks everyone for joining.
Thank you, everyone. Thanks for your participation. Thanks for all the questions. And thanks to the ASAP team for the opportunity to share what are the tools that we are using at USAID PEPFAR, and also to get this opportunity to talk with IPs to understand their concern and to respond as much as we can to share what we know with them. Thank you. Thank you, everyone.
Beautifully said. Thank you so much. Have a good day, everyone.
Thank you.